Good morning. Today's lecture is about status epilepticus, which means um, continuous non-stop seizure. We'll talk about the definition. The lecture today is a slightly more clinical. Probably you might not have the basic foundation to understand everything that is discussed here, but hopefully when you get to your clinical rotations, you will remember parts of stuff that I'll discuss here. But also in this lecture is different from the previous days because I intentionally selected this lecture to show you some research that I have done to show you how we identify knowledge gaps. When you work clinically, there are certain times or certain areas that you realize that it would have been nice if you had this or that. If you could treat this disease more effectively with better medications, it would be better if you could diagnose certain diseases. And when you work clinically, these knowledge gaps always going to up in your brain, and then you hopefully some of you will become clinical researchers in the future to conduct research to find answers to your research questions. I am, even though I am a clinician and I see patients on daily basis, but I'm also a clinical researcher, and I love the idea of, um, the two cannot go without each other. I love the idea of seeing patients, identifying problems, and then going and learning about how I can find solutions to those problems. And hopefully, at some point in the future, when you're more advanced in your studies, I'll come back and we talk about research methodology. All right, so I don't know if you have had your lessons on seizure, but seizure is when a focus in the brain starts to fire impulses uncontrollably and without any reason. So one neuron or a group of neurons decide to send signals to the rest of the brain and to the muscles. What happens when the signals continuously go to the muscles will start to contract, and you will have what we call convulsion. Convulsion is that continuous jerky movement of the muscles. So you will see people start to shake uncontrollably, and that's because the signals from the neurons in the brain are coming continuously. Same thing happens in the heart, right? When you have arrhythmia, when you have ventricular tachycardia, when you have ventricular fibrillation, atrial fibrillation, that's because one cell in the heart starts to send signals and doesn't follow the format of the electrical conduction in the heart, and they become independent. They become um, a focus of creating signals. So in the brain is the same. Normally, everything is regulated, but then sometimes for many reasons, and we will discuss some of those reasons. One uh, group of cells, one group of neurons in the brain starts firing signals, and these signals can from that area can go to the rest of the brain, and then the entire brain becomes that what we call an epileptogenic source, and then cause convulsion in the entire body. If that focus in the brain just sends signal to one part of the body, that's going to cause what we call partial seizures or focal seizures. Means the irritation is comes from just one part of the body, brain, and it goes to one part of the body. So that's just a brief description of seizure. How it happens is uh, these are the cells. These are the channels in the cell membrane. In order for a cell to get excited and send signals, the sodium chloride potassium channels work in a way that when the movement of these electrolytes through the channel create action potential and start the signal through the cell membranes. In order to this to happen, um, something has to excite the channels. We have two neurotransmitters that are worthy of knowing, especially when you deal with seizure. One of them is glutamate. This is glutamate, and this is GABA. Glutamate promotes movement of the electrolyte through the cell, and therefore can excite the cell, can start the action potential, can start the transmission of signals. GABA, on the other hand, blocks that channel, so prevents the electrolytes from going in and out. Most of the medications that we use to treat seizure are GABA agonists. They promote GABA activity. GABA goes, blocks the channels, the sodium channels, and prevents the cell from allowing the signals to transmit. Tonic-clonic seizure is when the, the, the signal that is started with one part of the brain now has a spread to the entire brain, and the entire brain is sending signals to the muscles to have convulsion. Convulsion has two elements. One is the tonic phase, when the body goes into a full spasm. Uh, they have this posture first, and then you go to clonic phase, which is known with having jerky movements, having convulsion, having shaking. So it's called tonic clonic seizure. That's a generalized seizure. But not all seizures are tonic-clonic. Some seizures are partial or focal, and the treatments sometimes are different. The etiology of them are also different. They're generally, classically, we have three stages for a seizure. The first stage is aura. So some patients, this is not for not all patients, but some of them, they kind of know when the seizure is coming. Sometimes they get some dizziness, sometimes some light flashes, some numbness around the mouth, some uh, physical sensations that they know their seizure is about to happen. That's called aura. Then they go into ictal phase. Ictal means seizure. So they have the seizure. Usually seizure lasts about 1 or 2 minutes. Most of the time it stops on its own. And then they go into a post-ictal phase. Post-ictal phase means after the seizure, when the shaking stops, they become very sleepy, very drowsy. And that drowsiness, that kind of lethargy should last about 20, 10 to 30 minutes. After that 30 minutes, they start to wake up and they come back. The, the problem is sometimes you go from the ictal phase, sometimes the ictal phase doesn't stop, so they keep seizing, right? That's what we call status epilepticus. So status epilepticus, by definition, is when you have seizures more than 5 to 10 minutes, non-stop seizure. Usually, it's only a few minutes, but if it goes beyond 5 or 10 minutes, then you have been stuck in the ictal phase, and that's why we call it status epilepticus. You'll hear status a lot, which means continuous. You hear status asthmaticus, which means the asthma is not getting better, it's just continuously getting worse. And status epilepticus means you are in ictal phase, you're having a seizure, and instead of stopping and going from ictal to post-ictal, you get stuck in the ictal phase. And that's when the brain, the entire brain, it continues to fire signals, and it doesn't stop. This results in release of a lot of free radicals and some neurotoxins in the brain that can kill the brain cells. Um, I forgot the number, but for every minute of status epilepticus, millions of neurons are going to die. So status epilepticus is a neurological emergency, and it's time sensitive, meaning that the more you wait, the longer the status epilepticus continue, the more damage you're going to have to the brain. So that's one option, that you're in the ictal phase and the ictal phase continues. Another possibility is that you go from ictal phase to post-ictal phase, but the patient never regained consciousness. And then they go back to either have seizure or the it looks like they're in post-ictal phase, but they're seizing without any convulsion. That's what we call a non-convulsive seizure, which means the brain is still seizing, the brain is still firing, but the body stops to shake, and then you don't see it. That's called non-convulsive seizure. So the second option was that you go from ictal seizure to post-ictal, back to seizure to post-ictal, and never regain full consciousness in between. That's another definition of status epilepticus. Again, this is when you have a status epilepticus, that means the entire brain most of the time is firing, entire brain is in full mode excitation. That increased metabolism in the brain, increased release of um, uh, neurotoxins in the brain, and this can have serious consequences that we will talk about. This is an electroencephalogram. When you put the wires around the brain and then you record the brain waves, you will see this is like a normal activity, and then you see this kind of earthquake like movement that's called. These are epileptogenic uh, signals that shows your patient is having seizure. So definition we already talked about is usually more than 5 or 10 minutes of seizure that doesn't stop, or um, multiple shorter seizures, but in between patient never regain consciousness. That's called the status epilepticus. And again, this is one of the neurological emergencies because it's time sensitive. The longer you wait, the more brain cells are going to die. And it's one of those emergencies that it requires multitasking. In one of the attractions of emergency medicine is that you have to multitask. You have to do many things at the same time. You have to think of many things at the same time. And we talked about it at the was it yesterday or the day before yesterday. You have to act on limited information, and you don't have a lot of time to decide. And in treatment of status epilepticus, you have to think of many things at the same time, and you have to do a lot of things at the same time. Hopefully, you're working with the team. In our institutions, we have residents, we have students, we have of course nurses, and usually one person um, becomes the team leader and assigns responsibilities to other people, and then everyone does a different task. But the team leader has to think of everything at the same time and uh, put everything together in a very short time. So what do we know? Again, because it's a time sensitive pathology, it's a time sensitive entity. The guidelines provide timelines. You have to do these things, like the first set of activities have to happen within the first 10 minutes that the patient arrives. Of course, the first thing that you do in any emergency is what? ABCD, right? You do your ABCD. So first, the moment you realize that patient is in status, you have to suction the airway. You have to make sure the airway remains open. Sometimes we have something called we put something between the mouth, oral airway or nasal trumpet to just make sure the mouth stays open. We suction them, put them on oxygen, check the finger stick, listen to the lungs, you do a quick 2 minutes primary survey that we talked about yesterday. You do your ABCDs. While you're doing your ABCDs, you have to think of the causes of the seizure. Some people have epilepsy. That means they have chronic seizures. That's relatively easy. Um, but remember, most of these patients are going to arrive seizing. They're altered. They cannot talk to you. They cannot provide any information to you. And sometimes most of the time, this happens in the street or they're at work, and this happens, the family is not with them. You have to collect some information to find out what could be the cause of this seizure. In children, you can have febrile seizure, right? If the fever goes up too quickly or comes down too quickly, some children are going to have seizures. There are medications that can cause status epilepticus. So you have a few minutes to collect some information, either from EMS, from the ambulance crews, sometimes from the parents or friends and relatives, quickly identify the cause. This is important because the treatment will depend on the cause. Sometimes the treatment doesn't work if you uh, don't know what you're treating. For example, um, a lot of people take, especially immigrants or people from or that they have exposure to TB, they have to take when the BCG becomes positive, the tuberculin test becomes positive, they have to take 9 months of isoniazid, and then to prevent going into full-blown tuberculosis. And then sometimes children, either the adults overdose on isoniazid, or sometimes children have access to the medication, they take isoniazid and they start seizing. The You will not be able to stop that seizure until you give the right treatment that is specifically for isoniazid overdose, which is B6. So you can give all the benzodiazepines, all the second line agents, everything you want, the seizure is not going to stop. So you have to quickly think of all the possibilities. You ask, is anybody at home suspected of having tuberculosis? Anybody at home is taking tuberculosis prophylaxis? Is anybody at home taking old days for asthma? We used to give theophylline to people, and then theophylline overdose caused the status epilepticus. So, what medications are people taking at home? What medication he is taking or she is taking, and what medication other people at home are taking that might be the cause of overdose. Another issue is another cause of seizure could be electrolyte imbalance, right? If somebody has severe hypocalcemia or severe hyponatremia, they are going to have seizures, and the seizure can go into uh, status epilepticus. So unless you treat the sodium or treat the calcium, no other medication is going to work. So you have a very, very, very short window to collect as much information as you can. Then you have to treat the seizure, right? We have three levels of treatment for status epilepticus. The first, we call them first line agents, second line agent, third line agent. First line agents are benzodiazepines. Benzodiazepines such as lorazepam, diazepam, or midazolam. And these benzodiazepines are GABA agonists, the same um, uh, neurotransmitter that I showed you. GABA blocks the sodium chloride channels and blocks the transmission of signals. So you give benzodiazepines, and most of the time, in about 65% of the time, benzodiazepines stops the seizure. But benzodiazepines are short-acting agents. They are usually disappear from the blood stream very fast. At the same time, when you give benzodiazepine, you have to give something, an anticonvulsant that is longer acting. So that's why you have two objectives here. You have short-term stop seizure immediately, and then give something to prevent the seizure from happening again. When you reach the 30 minutes time, um, that's where you know that your first line agent, second line agent hasn't worked. If the patient is still seizing, and to be honest, it's a very uncomfortable scene to watch someone seize, shake, foams are coming out of their mouth, eyes are rolled back, the whole body is like they can even break their bones, they can even dislocate their shoulders. That's how convulsions are severe, that you can dislocate shoulders. So it's a very uncomfortable scene to watch. So you want to do everything you can to stop the seizures from happening. But if you get to the point of 30 minutes, give or take, and this is not working, then you have to move on to the third line agent, and you have to give something to suppress the entire brain. And we have some medications that are aggressively put the brain in something like it, in the heart, you have asystole. In the brain, it's we call burst suppression. You basically suppress any activity in the brain, and then by doing that, you hope that that will buy you sometimes for the other medication to come and stop the seizure. So this is the sequence of events. First, the stabilization, ABCD, collecting as much information as possible that could guide your treatment. And then you give benzodiazepines, first line agents, and then you give second line agents, anticonvulsants that I will talk about. And then if that doesn't work, you go to the third line agent. And we will talk why that's not ideal. We have several types of benzodiazepines. We have lorazepam. The most common ones that are used in seizure are lorazepam and diazepam. And there's a lot of talk, a lot of research on which one is better. The argument for diazepam is diazepam goes through blood-brain barrier very quickly. We'll talk about blood-brain barrier tomorrow, but brain vessels have really sophisticated system that they don't allow every medication or every toxin to easily cross the the, the vessels to enter the brain. Diazepam, it has the pass, has the visa to go through that blood-brain barrier very quickly. So diazepam, as soon as you give the diazepam, within seconds, stops the seizure. But the problem is the volume of distribution for diazepam is very high, meaning it immediately distributes to the cells, and the blood levels drop and the patient can seize again. So it's very short acting, works very fast, stays in the blood for a short period of time. Lorazepam has it goes through blood-brain barrier slower, but then it stays in the blood for longer, so the chance of seizure coming back is less. But the point is, it doesn't matter which one you choose. You gotta give the benzodiazepine whatever you want, whatever you have, whatever is available to you, whatever you can get faster. You have to give it quick, and you have to give the right dose. One of the problems why we fail to treat the status epilepticus is we don't give the right dose, or we don't give it fast enough. And this becomes a problem that I will tell you about shortly. So these are the doses that you don't need, whether you choose lorazepam, your diazepam, midazolam. Um, it doesn't matter what you give. It has to be the right dose, and it has to be given very, very quickly. The problem is if you don't act quickly, if you don't give the benzodiazepine right away, or if you don't give the right dose, the it will be less likely to be treated. The problem in the brain is when you have that cycle of excitation, the longer that cycle goes around, the harder it becomes to stop it. It becomes more resistant to treatment. So even minutes delay in treating status epilepticus is going to cause resistance to treatment. And you will see that many studies have been done that even few minutes delay in giving benzodiazepine or underdosing benzodiazepine makes the status epilepticus resistant to benzodiazepine, and you lose one of your best ammunition in treating status epilepticus. Give benzodiazepines fast and give the right dose. And of course, we talked about the delay in treatment, how it affects mortality and morbidity. Remember when on the lecture we talked about the neurological emergencies, that brain can affect the heart. You can have continuous seizure can cause myocardial depression, and it can cause cardiac arrest. It can affect the breathing. It can cause pulmonary arrest. So it's not just the brain that is going to be damaged, but patient can have cardiac arrest. Patient can have respiratory arrest from continuous seizure in the brain. And most importantly, patient has may end up with cognitive dysfunction, cognitive deficiencies, and someone who is a completely has completely normal brain function after a bad status epilepticus, they might have some neurological deficit, some issues with cognition. That's definitely something you don't want. So you gave your benzodiazepines, and whether it worked, it didn't work, you have to give anticonvulsant almost at the same time. And these anticonvulsant also work on GABA receptors. They promote blockage of all those uh, channels. So we had three uh, options. We have fosphenytoin, we have valproic acid, and we have levetiracetam. ER docs in general, we like cheap old medications. Most of us, we use fosphenytoin. It works beautifully. It's cheap. You can buy it at Costco, get a bucket of it for $2. Well, they don't sell it at Costco, but it's cheap. It's old. It's proven has proven efficiency. So we like fosphenytoin. Neurologists, no offense, like fancy new medications. So levetiracetam, a lot of neurologists, they like levetiracetam or Keppra. It's a fancy new drug. And moody neurologists like valproic acid because valproic acid is also a mood stabilizer. That's a bad joke. But anyway, you have three options. You have fosphenytoin, valproic acid, levetiracetam, and in different institutions, different neurologists, different emergency physicians, they they tend to use different things. So a few years ago, we decided to conduct a study to see which one of these three is more efficient, which one of these three is safer to use for status epilepticus. There hasn't been any comparison between these three medications. So we designed a multi-center trial called ESAT, established the status epilepticus. The term established means a status epilepticus that doesn't respond to benzodiazepine. So if you give benzodiazepine and the patient is still seizing, that is called the established status epilepticus. So we enrolled anyone who had established the status epilepticus, and then we randomized them to either fosphenytoin, valproic acid, or levetiracetam in emergency in about 50 centers across U.S. Remember, status epilepticus is not something that you see on a daily basis. It's not as luckily, it's not as common. So we needed a lot of different centers to enroll patients to make sure we collect adequate, we enroll adequate number of patients, and we have adequate number of cases. This is the schematic of the use that I will skip. So we had, um, this is the number of patients in each category. We had 145 patients in levetiracetam group, 118 in fosphenytoin group, valproic, and 121 in valproic acid. So the study was blinded, meaning that we had a company make vials for us, vials of medication, that it looked exactly the same. So nobody could look at the vial and say whether what's in it. It could be fosphenytoin, could be valproic acid, could be um, uh, levetiracetam. So a study was blinded, randomization was done blindly. So patients didn't know what they were getting. Doctors didn't know what they were getting. That's the definition of a double-blinded study. So we did this study, and then this was the results. We enrolled about 384 patients, and among them, levetiracetam worked in 47% of patients. Fosphenytoin was able to stop the seizure in 45% of the patients, and valproic in 46% of the patients. That means all three had almost the same efficacy. That kind of tells you choose any of these three that you want. As in terms of efficacy, they're almost the same. But when you look at these numbers, it kind of makes you uncomfortable because you're dealing with a neurological emergency, something that really, really damages the brain. And then the best medications that you have only stops the seizure in 45% of, let's say 50% of the cases. Is that good enough? Is it acceptable with this modern medicine? right? It's not. So, well, we need to fix this. But for now, let's focus on this, that all three medications are, in terms of efficacy, are the same. And then we looked at the different age group. Do these their efficacy different in children, in young adults, or in elderly? They were almost the same. In terms of safety, what are the side effects? How the side effects are different in three of the side effects of these three medications. And again, the side effects, whether serious or non-serious side effects, were almost the same. So the conclusion of the study was that all three second line agents are similar in terms of efficacy and safety. That's not a bad result. So let's say you give your benzodiazepine, seizure continues. You give this, your second line agent, seizure continues. Now you're in trouble because now you have to go to a third line agent. Uh, the evidence is very hazy when you get to the third line agent. We have really, really good evidence, a lot of solid research that shows benzodiazepine work. It shows how they work, um, how fast they work, and we have good evidence for benzodiazepine. And with the ESET study, we also showed that we provided the evidence for the second line agents. How effective they are, how safe they are, we have good evidence. When it comes to third line agent, the evidence is very hazy. There's really not much research. A lot of it is from small studies or observational studies or ICU studies that are different from what we do in the emergency room. So the evidence is not as strong, and you will learn as you go forward that a lot of things that you learn or a lot of things that you do in your career are based on not much evidence. And that's why you need more clinical researchers to fill the knowledge gap. You need to work, you need to see patients, and you need to identify where the gaps are and then do research to fill those gaps, right? That's what you said at the beginning. So anyway, third line agents cause, these are the third line agents that we use. We put them either on midazolam drip, high dose midazolam drip, or propofol. Propofol is what killed Michael Jackson. It causes severe, it depresses suppresses all the brain activity, creates a flat line, and buys you sometimes, kind of cools down the brain until other medications kick in and work. And then pentobarbital is also another option. But the issue here is when you do this, you're suppressing the brain. What does that mean? That you're also suppressing the brain centers that control the breathing, right? So you have to intubate the patient. You have to put the patient on ventilator. To put the patient on the ventilator, you have to sedate them. You have to paralyze the patient. Now, what does that do to you is you will lose your ability to see whether the patient is seizing or not, right? If someone is sedated and paralyzed, you're not going to see whether the seizure is still going on or the seizure has stopped. That's why all of these patients have to be on EEG monitoring. They have to put the EEG on them to see the brain activity, but clinically, you lost your ability to determine who is seizing and who is not seizing. The why the treatment fails? We briefly talked about it. The one of the main causes is that you don't identify the cause of the problem. Sometimes patients have a brain bleed or they have a stroke, and that stroke or the brain bleed is irritating part of the brain and creating seizure. It's not uncommon for patients with stroke or for brain damage or brain mass, to seize. And then if you don't identify that cause, you're not going to be able to stop the seizure. We talked about electrolyte abnormalities. We talked about toxins, medications that can cause status epilepticus. And if you don't identify them, your treatment is going to fail. And then, well, some of the biggest problems that have been identified in the literature is that you either don't give the benzodiazepines at the right dose, you go slow, you go lower dose, or you don't give it fast enough. and that causes the status epilepticus to become resistant to treatment. And here are some of the reasons for seizure. Epilepsy syndrome is when there are some people who have chronic uh, seizures. They can go into a status epilepticus. Cerebral damage, whether this is from a traumatic brain injury, whether it's a stroke, it can be the cause of the seizure. Brain tumors. Sometimes the main manifestation of a brain tumor is um, seizure. Electrolyte abnormalities, whether it's sodium, sodium or calcium or magnesium. You need to treat them. Drug, alcohol overdose, or alcohol withdrawal. Patients with alcohol withdrawals commonly go into seizures. We have sometimes drunk patients in the emergency room, and they have, let's say, ankle fracture or some intra-abdominal pathology, and they're in the ER for hours, and because they're not drinking, they go into withdrawal and they start seizing from withdrawal, or they get admitted to the hospital for different reasons, but because they're not drinking, they go into withdrawal and they can have seizure. Encephalitis from infectious causes can also be the cause of seizure. And we talked about non-convulsive seizure. This is where seizures become very tricky because you don't see the external manifestations of seizure. The patient is not seizing, and there are no shaking. Sometimes there are like very subtle signs, like some subtle eye movements or some lip smacking, but many times you don't have anything. So there's no shaking, there's no external manifestation, and therefore um, you're dealing with seizure that you cannot see. That's kind of scary. So uh, many moons ago, um, I did a study in emergency department. We I had read in the literature about non-convulsive seizure, and we did a study. We enrolled anybody who was altered mental status, whether they were confused, in coma, they were lethargic, um, any kind of change in their mental status that we didn't know what was causing it. We did an EEG on those patients. And we identified that 5% of the patients with undifferentiated altered mental status were actually seizing, but without external manifestation. They had non-convulsive seizure or non-convulsive status epilepticus. This is kind of scary because roughly 2 to 10% of patients who present to the emergency department, they have some sort of altered mental status. 2 to 10% of millions of people is a large number, and out of those 2 to 10%, 5% of them are going to be seizing in the ER with you not seeing any manifestation from that seizure. So it kind of raised the awareness in emergencies that we need to do something about this. We need to identify these cases. We also did another study on patients who had convulsive status epilepticus. These are people who were treated successfully and they stopped seizing. And then we did EEG on those patients who initially were seizing, they were treated, and then they stopped seizing. We did an EEG on them, and about 14, 15% of them were still seizing. So it's not uncommon for a convulsive seizure to turn into non-convulsive seizure, even with aggressive treatment. So basically, they go from full-blown seizure to subtle seizures, but it never stopped. It just the external manifestations, the external shaking stops, but the brain continues to fire, and these can have really bad consequences. Um, this was a study done in 1996 by someone in ICU, and so this goes way, way, way back, that they realized that 50% of patients who are diagnosed with non-convulsive seizure, they're diagnosed a day or two later in ICU. So you lose 2 days of patients having seizure. which is really, really bad, like creates a lot of damage to the brain. So now this uh, prompted us that we need to come back to the emergency room. We need to have a higher index of suspicion and try to identify these seizures early on in the emergency room and not wait for the patients to go to ICU to have this. And my interpretation of when seizure goes from convulsive seizure to non-convulsive seizure, it's really when things can go from bad to worse, right? That's because when patient is seizing in front of you, you can see the shaking. At least you know whether your treatment is working or not working. When they stop seizing, but they are still altered, is the patient still seizing in the brain or not? So we need to figure out something to identify these early. This is a standard EEG machine, electroencephalogram machine. It relatively large computer, and then you have to put a lot of uh, leads on the brain, different parts of the brain, about 16 to 20 different leads, a lot of wires. So this is a very nice, clean picture. It probably happens in some EEG lab. But just imagine you're in the emergency room. The emergency rooms across the country, globally, they're all crowded. A lot of patients are in the hallway. Or even if not in the hallway, you have a patient in a patient bed. They have they're on monitor, they have a lot of wires on them. The nurse has to go to the bedside, give them medication, put IV. Patient needs to go to CAT scan, to X-ray. Can you imagine this person sitting uh, next to the bed in this nice condition to do EEG? It's not it's not convenient. So for many, many years, we knew that we had this problem with the non-convulsive seizure, but getting an EEG was not is not an emergency department thing. And if you have someone who is you're suspecting that they might have seizure, you don't want to send them to a different floor to an EEG lab to have a proper EEG because you don't want that patient to leave the ER. So for many, many, many years, even though we had these machines, we couldn't do anything because these are really not emergency department compatible um, uh, tests. So in 2010, 2011, one of the I had two scientists, one neurobiologist and one bioengineer at the State University of New York when I was working, that they came up with the idea of this portable wireless EEG. It's portable. You can pull they designed something like a shower cap. So instead of putting the wires leads one on one, you could pull the shower cap on the patient's head, and later it became, the other companies made fancier stuff like this first one is called Cerebral. So you put this around the patient's head, and the device can be on patient's arm or on the head, and this patient can go to different areas. The nurse can get to the bed, and the device wirelessly sends the EEG signals to an epileptologist that can be sitting at home or even a different country, and still they can see the EEG and they can read it. This was a game changer because now this is more ER compatible. This is something that we can do in the ER. It doesn't interfere with our clinical care, and this suddenly they become very popular, and now there are more than one device. I have no financial conflict of interest. I don't own any shares of those companies. I was never get paid by them, so no financial conflict of interest. I just use them to do my research. One of the so people first had the doubt about these devices. They said maybe a standard EEG machine is more accurate. Are these devices accurate enough to tell us whether the patient has seizure or not? We did a study. We had the patients um, uh, have the EEG leads on them, and then we had a signal splitter that went to both EEG machines. So every patient had an EEG at the same time, but recorded by two devices. And then our epileptologist read those EEGs and they said that the accuracy, the diagnostic accuracy of these devices was as good as the standard EEG. So that kind of relieved that uh, doubt in our neurologist's mind. And then this was a different study. We did, we said, if you incorporate EEG in your day-to-day practice, does this going to help you change your differential diagnosis, change your management? Because remember, if you do the EEG, not only it helps you if the patient has seizure, but if you do an EEG and an EEG is negative, it rules out a bunch of neurological issues, right? If you have a normal EEG, the patient probably doesn't have a encephalitis, less likely to have a brain tumor, less likely to have other brain issues. So not only it helps you diagnose seizure, but it also helps you uh, rule out a lot of other things. And about half of the time, the completely the direction of the management changed because of the EEG results. So the intubation is a big deal for in status epilepticus. We want to delay the intubation as much as possible for the reasons that I mentioned before. Because when you intubate someone, you have to sedate them, you have to paralyze them, and then you lose your ability to see whether the patient is seizing or not. So you have to delay the intubation as much as possible. This is very hard because again, you have someone who is foaming in the mouth, a lot of secretions are coming out. You have to give them a lot of benzodiazepines, which are that are respiratory suppressants, and it's a very uncomfortable thing to watch. And you want to secure the airway. The urge is to let me secure the airway. Let me make sure this patient's airway remains open. Let me make sure the breathing is open. But this is one case that you have to delay the intubation as much as possible because you don't want to lose your ability to see the convulsions. The concern, one main concern is that you're giving them a lot of benzodiazepines, and benzodiazepines can make them stop breathing. There was a study that was done by one of my colleagues in 1990 something. It was very, very old, and they randomized patients to benzodiazepines or placebo. So people who were seizing, half of them got benzodiazepine treatment, half of them got nothing, right? And patients who didn't get anything, they were the one who actually had more respiratory, cardiorespiratory suppressions. Not, it wasn't benzodiazepines, it was the status epilepticus, it was the seizures that was causing the thing. And actually, when you give them benzodiazepine, you reduce the risk of respiratory suppression, myocardial suppression. And that kind of changed the perspective that don't worry about the benzodiazepine. If you aggressively treat the seizure, you're going to have less chance of um, respiratory issues. So I want to come back to the issue that we had here. Again, the best medications that we have on this day and age only stop seizure in 50% of the time. And when we did this study, we all agreed this is not good enough. It really it's not good enough. It's like going to a gunfight with a knife, right? So what can we do to change that? What can we do to make our studies, our treatments more effective? This is a kind of a scary graph, but just imagine this is a synapses. You have two neurons. Neurotransmitters are being going across, and then you have um, uh, the, the channels that we talked about. There is one neurotransmitter called NMDR. These they are one of the reasons why excitatory cycles continues. These channels are responsible for making seizure more continuous and more prolonged. And if you find an agent that can block these channels, it's very likely that's going to help you treat the seizure. This is from a lot of basic science research that that all had shown that NMDAR receptors are responsible for prolongation of seizure. And we had a medicine called ketamine that actually blocks those uh, channels. So going back to the pathophysiology, when you have prolonged status epilepticus, the GABA receptors kind of decrease their function. Prolonged seizure, I remember I said when you with seizure, the longer the seizure goes on, the less likely it will respond to treatment. It because the activity of GABA receptors that are responsible for stopping seizure decreases. Therefore, all the first and second line agents that are all GABA agonists are not going to work. And then as that happens, NMDA receptors become more and more active, and NMDA receptors are what are responsible for that excitatory cycle that can create hyperexcitability. And now we enter the a refractory status for a refractory status epilepticus. So ketamine has been around for ages. It's a hallucinogen. It can cause hallucinations, but it also a sedative agent, and it also does. It's a very good pain medicine. We have been using ketamine in the emergency room for ages. The anesthesiologists love it. We use it for intubation. We use it for pain management. We use it for conscious sedation. Um, I remember there was a day that every child that required laceration, we had to wrap them in sheets and have their parents hold them down to do the laceration, kicking and screaming. It was a painful thing to do. Now we just give them IM ketamine and they're out for 20, 30 minutes and we do our lacerations and then they wake up after 20, 30 minutes not remembering anything. The ketamine is a dissociative agent, meaning that it blocks the connection between outside stimuli and the brain. So the eyes are open, they're breathing, but they have no uh, concept of pain or any other thing they have. It's a dissociative agent. It kind of breaks the connection between brain and the environment. And that's why it's a drug that's frequently abused because of that hallucination or that dissociative quality. So ketamine has been around for many, many, many decades and it's been used for different reasons. But now we know that it actually, ketamine can block the NMDA receptors and it might be able to break that cycle of hyperexcitability in the status epilepticus. This study was done by one of my colleagues, is a basic scientist, and they created seizure in rats, and then they gave them ketamine. As you can see here at the bottom line, these are the rats that were given ketamine, the number of stimulus, and then the top ones are the ones that were not given uh, ketamine. The number of stimuli continue to go up. This is what we call, as I was speaking at the beginning, this is called translational science, which means basic scientists do a lot of work in the lab. They do a lot of work on animals, but at some point that knowledge has to be translated into clinical practice and has to come to the patient bedside and benefit the patient. And this is a classic example of how basic science research can be used clinically. So all these research were done in the past that how ketamine affects the brain, how ketamine decreases the excitatory pathways in the brain, and then we are going to use that to help us uh, control seizure. So our next project We actually just got a $30 million grant from National Institutes of Health to do this study. Um, it's going to be conducted in 60 different medical centers across the US. We are expecting to enroll about 800 patients with established status epilepticus. So the previous study, we called it ESAT. This one is KESAT, ketamine for established status epilepticus. The enrollment, we have already recruited the sites and we are about to start enrollment by end of 2025. And again, we are expecting to enroll about 800 patients and hopefully, we're really, really hoping that ketamine, adding ketamine to a second line agent like levetiracetam will improve the efficacy of the treatment from that 50% to much higher and will be more effective to um, stop the seizure. We're going to, because this has never been, ketamine has never been used in the emergency room for status epilepticus, we have to find the right dose. So we are randomizing patients to 1 milligram per kilogram, 3 milligram per kilogram, or placebo. These are the details. And that's it. Yes, sir. So it's a ketamine has some what we use ketamine for is for short term, right? It's not a medication that you put someone for a long term, but they're using ketamine for depression and for chronic back pains for long term. That's a different issue. But in the emergency room, we want to use it for short term. We use it for conscious sedation, we use it for acute pain, and for status epilepticus, we use it to stop the seizure. I don't think it's going to be something maybe in the future, maybe with future research, it will show that if you add ketamine to the daily regimen of patients with epilepsy, it will help. But for us, it's an acute medication that we're going to use it quickly to treat the disease. But what you're saying is actually perfect because one of the side effects of uh, ketamine is called what we call emergent reaction. So I have seen kids that I have given them ketamine, and then as they are waking up, they they have really, really horrible hallucinations. They see their, parents and they think they're monsters. They scream. They're really, really afraid. It's something that usually goes away very quickly. So ketamine has the ability to cause those hallucinations. And if someone has history of psychosis, that could be a problem. But again, this is short term, whether that impacts them in the long term or not, to be determined. That's another knowledge gap. We'll leave that for you to do the research. Any other questions? Sorry, I spoke fast and it was a little bit um, less basic, but I hope I hope you enjoyed it. Thank you.